Hi everybody, and welcome to our module on Streptococci. So here's our algorithm for identification of gram-positive bacteria, and once you identify that you're dealing with a gram-positive cocci, the next test you want to do is the catalase test. Catalase-positive bacteria are staph, and they tend to occur in clusters. Catalase-negative bacteria are strep, and they tend to occur in chains. Once you know you're dealing with a strep, the next test is often to see what hemolysis pattern you're dealing with on blood agar. We can differentiate strep based on whether they are beta hemolytic, alpha hemolytic, or gamma hemolytic. And so in this module, we're going to talk about all the different strep, and that includes the strep pyogenes, the strep agalactae, strep pneumonia, strep viridans, enterococcus, and strep bovis. So I've listed the names of all the strep infections on this slide here, and as I said in the last slide, they're all gram-positive cocci, they all form chains, and they are all catalase negative. So the first strep bacteria we'll talk about is strep pyogenes, which is also called group A strep based on the Landsfield classification system, and it has a couple of special features that you need to know about. Strep pyogenes has an enzyme called pyrrolidinyl arylamidase, and that's a mouthful. Most people just say it is PYR positive. This enzyme can hydrolyze a substrate called L-naphthalamide beta-naphthalide, and when it hydrolyzes it, it converts it into beta-naphthalamide, and this can be detected by a color change with a detection reagent. So once you know you're dealing with a beta hemolytic strep, testing for PYR positivity is a very rapid way to determine that you're dealing with strep pyogenes because it's the only beta hemolytic strep that is PYR positive. Strep pyogenes also has an important virulence factor called the M protein, which inhibits phagocytosis, and I talk about this in more detail in the module on virulence. Strep pyogenes causes a number of different illnesses, but they generally fall into three categories. It can cause a couple of infections. It can cause pharyngitis or sore throat, which most people call strep throat, and it can cause a couple of skin infections, including cellulitis and impetigo. It causes several toxin-mediated diseases. These include scarlet fever and necrotizing fasciitis, which we'll talk about in this module. And then you should also know that strep pyogenes is a potential cause of toxic shock syndrome. Now, the classic cause of toxic shock is Staph aureus, and I talk about this in the module on staph. But just know that toxic shock can also be caused by strep pyogenes. And then strep pyogenes causes a couple of immune-related diseases. These include rheumatic fever and post-strep glomerulonephritis, and we'll talk about these in this module as well. About 15 to 30% of pharyngitis cases or sore throats are due to strep pyogenes. So you should know that if you ever have a sore throat, the most likely cause is a virus. Strep is much less likely. But still, it's important to identify and treat strep pyogenes for a couple of reasons. First of all, the usual things. We don't want the disease to get transmitted, and we want to limit symptoms. But importantly, that if you don't treat strep pyogenes early, patients are more likely to get rheumatic fever, which is a very serious complication of the strep infection. There are two ways to diagnose a strep throat. You can diagnose it by a throat culture, and there is also a rapid antigen test. It's about 75 or 80% sensitive. So if it's positive, you can go ahead and treat. A lot of pediatricians do the rapid strep test in the office. If it's negative, you still often have to send a throat culture because the test may have missed it. And one thing to always remember about strep pharyngitis is it's one of the few infections that can still be treated with penicillin. Strep pyogenes is generally penicillin sensitive. Now, a lot of pediatricians like to use amoxicillin, and that's because it tastes better in liquid form, so children will take it. And then you can also use a cephalosporin. But always remember, especially for your boards, that penicillin is an acceptable treatment for strep pyogenes, strep throat. Strep pyogenes can cause two important skin infections, cellulitis and impetigo. So cellulitis, it looks like this. It's usually an extending red infection of the subcutaneous tissue. And then impetigo looks like this over here on the right. It's described as honey-colored crusted lesions. Both are commonly caused by strep, but they can also be caused by Staph aureus, and I talk about this in the module on staph. So when you're choosing antibiotics to treat both of these infections, you need to pick an antibiotic that covers strep and staph in order to make sure that if Staph aureus is present, it gets treated. Scarlet fever is a rash that occurs following strep pharyngitis, and it occurs because of a skin reaction to a toxin secreted by the bacteria called erythrogenic toxin. And one thing that's high yield to remember about this toxin is that the gene is not found in the bacterial's genome. The gene is transferred to the bacteria by a lysogenic bacteriophage. Scarlet fever begins with fever and a sore throat, typical strep pharyngitis symptoms, and then it's followed by a diffuse red rash. The rash typically has many small papules, so it's described as sandpaper skin. It starts in the head and neck, and then it expands to cover the trunk. And this is a picture from an old textbook. At the bottom of the screen, there's a child with scarlet fever on the right and a child with measles on the left. You can see that measles looks like a typical maculopapular rash, whereas scarlet fever looks more like a sunburn with those small papules making it have the sandpaper skin. Of course, in real life, there's a lot of overlap of the two conditions. Another classic finding of scarlet fever is the presence of a strawberry tongue. This is a picture of a strawberry tongue on the right side of the screen here. Now, you can also get a strawberry tongue in a vasculitis syndrome called Kawasaki disease, and Kawasaki disease also occurs in children and also has a rash. In real life, it can be difficult to tell scarlet fever apart from Kawasaki disease, but for purposes of a board question, always look for the presence of a sore throat, and that will tell you that you're dealing with a child with scarlet fever and not one who has Kawasaki's disease. In scarlet fever, the skin eventually desquamates, and importantly, the palms and soles are usually spared by the rash. There are only 3 infectious rashes that typically involve the palms and soles. The most important is syphilis, but the palms and soles can also be involved in Rocky Mountain spotted fever and Coxsackie virus infections. Necrotizing fasciitis is a very dangerous and severe skin infection caused by strep pyogenes. It's an infection of the deep tissues like the muscular fascia and the subcutaneous fat. And it's caused by strep pyogene strains that produce the streptococcal pyrogenic exotoxin, which gets released and leads to a lot of the symptoms and sequelae. It's often fulminant and deadly. The infection spreads along the muscular fascia, and it requires urgent surgical debridement. So when you work on surgical rotations in the hospital, you will often get consulted by the emergency room for people with skin infections. Most of those skin infections will be simple cellulitis, but the reason the ER is consulting you is because they are questioning whether it has turned into necrotizing fasciitis, and they want to know whether the patient needs to be taken to the operating room. There are 2 types of necrotizing fasciitis. The first type is polymicrobial. It's often caused by anaerobes like Bacteroides and Clostridium, and this occurs in diabetics and other people who are immunocompromised and get severe skin infections. The type that everyone fears is the type 2. That's what's caused by group A strep or strep pyogenes. It's also sometimes caused by staph. And this one occurs in otherwise healthy people after a skin injury, sometimes a minor skin injury. So the classic case for strep pyogenes necrotizing fasciitis is someone who has a minor skin trauma. Often it's a biker who has a fall or someone who's been hiking in the mountains. They get redness or warmth at the site of trauma, and sometimes this can be confused with cellulitis. Remember what I said, this is why there are often surgical consultations done in the ER for people with skin infections. One key finding is that there will usually be pain that's out of proportion to the exam, so even though it's a small amount of mild redness, it will be exquisitely tender, and then when it becomes bad, it can cause fever and hypotension, which makes it obvious that you're dealing with a case of necrotizing fasciitis. Next, let's talk about rheumatic fever. This is an immune sequelae that follows a group A strep pharyngitis infection. Infection with Streptococcus leads to the production of anti-strep antibodies, and those antibodies cross-react with tissue antigens, and this leads to rheumatic fever. This is considered an example of a type 2 autoimmune or hypersensitivity reaction. There are a couple of classic pathology findings for rheumatic fever that you should know about, especially for step 1. The first is the presence of Aschoff bodies. These are nodules in the heart, and they contain inflammatory cells. They're a form of granuloma. This is a picture of one right down here. These are cardiac myocytes, and this is an Aschoff body embedded within it. And if you see this under the microscope, it's pathognomonic for rheumatic carditis. Another classic finding is the presence of Anichoff cells. These are some of them over here in this picture. They are these macrophages with a lot of cytoplasm and an owl's eye appearance to them. And then finally, there is a toxin secreted by the bacteria called streptolysin O. So anti-streptolysin O antibodies, or ASO antibodies, will become elevated in patients who have rheumatic fever. So elevated ASO titers are suggestive of rheumatic fever. So there are many, many symptoms of rheumatic fever in many different systems in the body, and the mechanism of all these features are poorly understood. The way you diagnose rheumatic fever is by looking for presence of the Jones criteria. So the Jones criteria are a series of major and minor findings, and if you have enough of them, then you can make the diagnosis of rheumatic fever. So let's go over the minor Jones criteria first. Most of these are relatively non-specific. These are things like presence of fever, presence of arthralgia, which is joint pains, a prior history in the patient of rheumatic fever, because if you've had it once, you're more likely to get it again. Elevated white blood count, SED rate, or C-reactive protein, all of these are markers of inflammation, or a prolonged PR interval on the EKG. The major Jones criteria findings includes carditis, which can be myocarditis or damage to the heart valves, Polyarthritis, so this is not just going to be pain in joints, but this is going to be inflammation of multiple joints. Chorea, which is a movement disorder. Erythema marginatum, which are pink rashes. They're usually big circles on the trunk or on the legs. And then subcutaneous nodules. And so in order to have rheumatic fever, you need to have 2 major or 1 major and 2 minor criteria, along with evidence of a prior strep infection. So clues to diagnosis of rheumatic fever, especially in board questions, is that they will describe a patient with a sore throat or upper respiratory infection followed by the development of joint pain and often a new murmur. And these are evidence of rheumatic fever in the joints and in the heart. The treatment for rheumatic fever is to give penicillin. Usually it's administered when the diagnosis is made to clear any potential lingering strep throat bacteria. And then in addition, patients who've had rheumatic fever often take penicillin indefinitely for prevention of recurrent infections, because if they ever get another strep throat with strep pyogenes, they can get very, very sick. And just let me mention here that there are 2 types of cardiac involvement that can occur in rheumatic fever. In acute rheumatic fever, the carditis can lead to severe valve disease and heart failure. And then patients who recover from rheumatic fever years later often develop mitral stenosis. Very rarely they could get aortic or tricuspid stenosis. And the stenosis is the result of fibrosis and thickening of the mitral valve as a sequelae of the immune dysfunction that occurred in the setting of rheumatic fever. When you think about rheumatic fever, you should also think about post-streptococcal glomerular nephritis, because they are both sequelae of strep pyogenes infections. Post-streptococcal glomerular nephritis is the nephritic syndrome. It usually occurs 2 to 3 weeks after a group A strep infection. And one thing to know is that there are certain strains of strep called nephritogenic strains, and these have particular M protein subtypes that cause nephritis. Something that's very interesting about strep pyogenes is that it's very rare for a patient to get both rheumatic fever and glomerular nephritis. They usually get one or the other, and that's because certain M protein subtypes are associated with rheumatic fever and others are associated with glomerular nephritis. Next strep bacteria we're going to discuss is called Strep agalactae, and this is also called Group B strep. It is a beta hemolytic bacteria, just like Group A strep, so you can remember that Group A and B strep are the 2 beta hemolytic strep. A couple of special features of this bacteria that you should know about. The first one is that it makes something called the CAMP factor. So CAMP factor is named for its inventors. They each have an initial that's in the name, C, A, M, and P. What CAMP factor does is that Staph aureus makes a substance called beta hemolysin that can perform hemolysis. CAMP factor enhances the lysis by beta hemolysis. So if you plate Group B strep and staph on a plate together, you will get a classic finding like what I've shown in this picture down here. So in this picture, Staph aureus has been streaked across the plate like this. This is it, this white streak right here. And then Group B strep has been streaked in this direction down the plate. You can see a faint line of it going down right here. So I'm clearing the lines away, and you can see that where the 2 lines cross, there is this widening zone of hemolysis, this darkness right here around it. And that extra widening zone of the darkness, you can see it's much wider than the zone around the other portions of the Staph aureus. That widening zone of hemolysis happens because of the CAMP factor being produced by the Group B strep. It makes more hemolysis occur from Staph aureus than you would get in sections of the plate over here where it's just Staph aureus by itself. Second unique feature about Group B strep you should be aware about is that it hydrolyzes the compound hipparate, and this means that it will alter the color of a hipparate test. Hipparate test is a very rapid microtest that can be done to very quickly identify the presence of Group B strep. The most important thing to know about Group B strep in terms of infections is that it colonizes the vagina, so it causes infections in newborn babies who pass through the birth canal. Babies can get infected either in utero or during birth, and for this reason it is one of the common causes of pneumonia, meningitis, and sepsis in newborn babies. Now, most pregnant women are screened around 35 to 37 weeks right before they're getting ready to deliver. They're screened with a vaginal culture, and if they're Group B strep positive, they get prophylaxis a few hours to delivery, usually with either penicillin, ampicillin, or cefazolin. But women who aren't screened or who have ineffective treatment with antibiotics can pass on the bug to their babies, and this is why it can cause infection in newborns. Next strep bacteria is strep pneumonia, and this is classically described as a lancet-shaped gram-positive cocci. You may know that a lancet is a blade, so this is going to be a cocci that's a little bit elongated with a little bit of a pointy edge to it. Some of its virulence factors include IgA protease. It's one of the bacteria that makes an IgA protease. And then a very important and high-yield virulence factor to know about is the presence of a polysaccharide capsule. Remember that some bacteria contain a capsule to help them survive inside the body. This capsule prevents phagocytosis, and it's the basis of the vaccine. The vaccine is from the capsular material, so elderly patients often get the pneumonia vaccine, and they are getting portions of the capsule so that they will develop antibodies to them. Another important thing to know about that's a result of the capsule is that asplenic patients are at increased risk for sepsis. So your spleen helps eliminate capsular bacteria. So patients who've had a splenectomy or patients who have sickle cell anemia, these patients plug up their spleen with sickle cells and they are functionally asplenic. So both of these groups of patients are at increased risk for sepsis from strep pneumonia, and that's because they have trouble clearing the capsular bacteria without a functioning spleen. Strep pneumonia causes a number of infections. It's a classic cause of lobar pneumonia. That's where it gets its name from. It's also a very common cause of meningitis. It can cause otitis media, which is an inner ear infection that classically occurs in children. And people who have bacterial sinusitis often have infection with strep pneumonia. The next strep bacteria is the viridans group strep. So this is a group of similar bacteria that's usually just called strep viridans, but it's actually several different bugs. These bacteria do not have a Lancefield grouping, so they are not group A, B, C, or D, or anything like that. They're all normal mouth flora, and some of them cause dental caries or cavities. Strep mutans is the one that usually does this. There's also another member of this group called strep sanguis, which is a classic cause of subacute endocarditis. So subacute endocarditis is a bacterial infection of the valves of the heart that has a slow onset, and generally patients are less sick. This is in contrast to patients who have Staph aureus endocarditis, who are often much sicker and get sick very quickly. Strep viridans is not that virulent, so it needs an abnormal valve to cause infection. In other words, if you have a normal healthy valve, this bacteria usually cannot cause endocarditis. One thing to know about these bacteria is that they synthesize dextrans, and dextrans can bind to fibrin. So where is fibrin going to be present on the body? Well, it's going to be present where there is endothelial damage. So the way this classically causes endocarditis is someone has mitral valve prolapse and they have a damaged mitral valve, and there is some fibrin sticking out into the bloodstream. And then the patient gets bacteremic from a dental source, maybe they had some dental work done, and the dextrans present on these strep viridans can then bind to the valve and cause endocarditis. A pearl that's often present in board questions is a recent dental procedure. So if you see someone who had recent dental work, especially with a history of mitral valve prolapse, and now gets endocarditis, they're describing a classic depiction of a strep viridans group endocarditis infection. The next streptococcus that we'll talk about is Enterococcus. There are two of these that are medically important, Enterococcus faecalis and Enterococcus faecium, but they both cause similar infections, so most people just call it Enterococcus. They are normal colonic bacteria, and they are Lancefield group D, and the two infections that they can cause are UTIs, and they are a rare cause of endocarditis. One thing that's very high yield to know about Enterococcus is that it is resistant to a lot of antibiotics. It's definitely resistant to penicillin. And there is a variant of Enterococcus that is resistant to vancomycin. It's called vancomycin-resistant Enterococcus, or VRE. And this is a very dangerous hospital-acquired infection. Only a few antibiotics can cover this. And if hospitals have outbreaks of VRE, they have to go to great lengths to try and eradicate the bacteria. So let's talk in a little more detail about Enterococcus and antibiotics. Enterococcus is relatively resistant to cell wall agents when they're used alone. So penicillin, ampicillin, and vancomycin, these drugs by themselves don't work very well. The bacteria is also impermeable to aminoglycosides, so they're never used alone. However, it turns out that when you use agents in combination, they have a better effect than either agent alone. This is called synergistic therapy. So vancomycin and gentamicin are often given together to treat Enterococcus infections. So is the combination of AMP and GENT. And again, the combination works better than either drug alone. VRE, or vancomycin-resistant Enterococcus, is often treated with linezolid or daptomycin. The niche for these two drugs is treatment of VRE. And any time you're treating Enterococcus, sensitivities from the microlab are very important. The particular strain in a given patient may be sensitive to vancomycin, and then you can use that drug alone, but you won't know that until you test it in the lab to see how sensitive it is to one particular agent or another. Enterococcus is a rare cause of UTIs. These are often hospital-acquired UTIs. They're usually associated with catheters. And one thing to know in actual practice is that anytime someone in the hospital gets a UTI, you need to remove the catheter. And just doing this alone sometimes cures the infection. And one high-yield thing to remember about Enterococcus is that it is one of the two bacteria that cause UTIs that will be negative for nitrites. So most bacteria that cause UTIs, especially E. coli, produce nitrites, and you can detect this on a urinalysis. The two that do not produce nitrites are Enterococcus and Staph saprophyticus. So if you see a board question where it looks like a UTI with white cells and bacteria in the urine, but it's negative for nitrites. This is one of the bacteria you should think of. Enterococcus is a rare cause of endocarditis, and when this happens, it's usually after manipulation of the genitourinary tract. So it might be a man who's just had a resection of the prostate. There's a procedure called a TURP, or a transurethral resection of the prostate, that's commonly done for enlarged prostates, and that can introduce bacteria into the bloodstream that aren't ordinarily there. Or someone who's had a cystoscopy, so maybe they had hematuria and they were being investigated for bladder cancer, so they had a scope put into their bladder, and this can sometimes introduce bacteria into the urine that aren't ordinarily there. Because vancomycin and gentamicin covers enterococcus, it's often used as empiric therapy in endocarditis before culture data are available. So if a patient comes into the emergency room with obvious endocarditis, you'll start vanc and gent so that enterococcus is covered, and later you can change the antibiotics once you determine what the bug is. And as I said before, synergistic therapy of dual antibiotics is what you want in order to treat enterococcus. And then the final Streptococcus bacteria that I'll mention is Strep bovis. This is part of the normal colonic bacteria. It is a very, very rare cause of bacteremia or endocarditis. And the most important thing to remember about Strep bovis is that this is strongly associated with colon cancer. So if someone presents with endocarditis and the bug comes back as Strep bovis, one of the things you want to do is work them up for colon cancer, because there's a very high chance that it's present and that the breakdown of the colon wall is how the bacteria got into the bloodstream. And that concludes our module on strep.